Welcome to the Mind Meets Medicine podcast, where we believe the future of healthcare is mind meeting medicine. Hi, I'm Kayla, a licensed therapist and founder of a mental health care clinic.
And I'm Dr. Sir, a board-certified psychiatrist.
Together, we will join the fields of medicine and psychology to provide education, elevate guest perspectives, and foster curious, informed conversations.
Welcome back to Mind Meets Medicine. I'm Sir.
I'm Kayla. Today we have such a special guest with us.
Yeah, we are so lit. This guest is becoming a celebrity in our neighborhood by the fantastic care that our patients are getting. Quality,
Expertise.
well-rounded,
Yep.
numerous offerings, personalized treatment, focused on women's issues. We are really blessed, honored, feeling favored to be in the presence of greatness. Teeing up Dana. Tell us about yourself. Why are you here?
Hi, guys. Thank you so much for having me today.
Welcome to Mind Meets Medicine.
I'm Dana Ramsey. I'm thrilled to be here. I'm a certified nurse midwife. I've been in practice for 20 years. I am Yale trained, grew up in Santa Cruz, happily practicing in a multidisciplinary practice that I opened 5 years ago. It's called Nurture Women's Health and Fertility. We do a mix of fertility care, but also really focus on the whole woman, providing care all through the reproductive years into perimenopause and menopause.
So you're seeing people ages...
Anywhere from teens for their first pap smear all the way through, I have an 85-year-old patient. And so we are really able to meet women where they are in the stage that they're at, maybe having some hormonal issues, maybe not, and not using the traditional medical model where insurance reimbursement is really the center of practice. Really, we put the patient at the center of practice, at the center of care and what they need. And so it's made practicing medicine and the art of medicine such a better experience for the patient as well as the provider.
And what does Nurture look like?
Yeah, Nurture is a multidisciplinary women's health practice that has Western medicine approach, functional medicine approach. We have a team of practitioners that includes a pelvic floor physical therapist. We have a team of 3 psychotherapists that work that specialize in women's health and women's issues, as well as a functional nutritionist that can help with sort of more of the lifestyle part of medicine that so often goes to the wayside because we don't have the time to offer those services.
Dope.
Yeah.
And you're bringing on
We-
the new year.
Yeah, in the new year, we have a physician. Dr. Sienna Titan will be joining our team, which we're very thrilled about. She is a pelvic pain and endometriosis specialist, and she will be offering concierge OBGYN services through Nurture.
We got to talk about endometriosis too in the future. And there's an interesting study I was doing for Journal Club, or that's coming up for Journal Club with one of our residents, talking about how the relationship between endometriosis and psychological trauma, and how there's maybe a demonstration of an independent causal relationship between having traumatic experiences and the likelihood of developing endometriosis.
Interesting. Yeah,
But we'll tee that up for...
lovely.
Yeah.
That would be great.
Oh, I'm so excited to dive in today.
Let's do it.
Let's do it. Hey, Dana Ramsey.
Hi.
Welcome to Mind Meets Medicine.
Hi.
You're here.
Yeah.
It's happening.
I'm so excited to have you. Thank you so much for coming today.
Aw, thank you.
Would you like to introduce yourself?
I'd love to.
Yeah.
So I'm Dana Ramsey. I'm a certified nurse midwife. I've been practicing women's health for about 20 years now. Always knew, like really, like back to high school, knew I wanted to work with women, deliver babies, do all that amazing work. Never thought that I would specialize in perimenopause, menopause. But as time goes on and we grow as professionals and humans and women and mothers, we often find that there are areas within medicine that are kind of blind spots. And after about 15 years of practicing corporate medicine, I realized there was quite limitations around what I could provide to patients. And so about 5 years ago, I left corporate medicine and decided to kind of dream up my dream women's health clinic. And I really had no clue if it would work or not. And 5 years later, I could say that we are absolutely killing it in terms of what we're able to offer. And really, it's as simple as putting the patient in the center of care. And so, so I've been a certified nurse midwife for about 20 years now, spent the first half of my career delivering babies, and now going into the second half of my career caring for women not only in the perimenopause, menopause space, but also doing quite a bit of fertility work, also starting to venture a little bit into pelvic pain. And so again, kind of like focusing on those areas where corporate medicine doesn't necessarily have the bandwidth to individualize care.
Yeah. And so today we get to learn from you and pick your brain about perimenopause and menopause, which is a big topic.
Yes.
And we are ready to learn.
Yay.
Yeah.
Yes.
I would like to start with, why do you think, just kind of zoom out, why do you think this is a gap historically in the traditional medical model?
Yeah. Well, there's a few reasons for that. First of all, we spend a lot of our healthcare dollars in women's health studying pregnancy. And oftentimes, once women kind of complete that part of their reproductive life, there's not a lot of attention and research dollars that go into studying perimenopause and menopause. And so prior to about 2000, we had very little, sadly and embarrassingly low amounts of research on the topic. And so in early 2000, late 90s, they decided, okay, let's fund it. We had some small studies. So they did a huge study called the Women's Health Initiative study. And basically, its goal was to prove that what the small studies had said, which was that hormone replacement therapy, using hormones to replace what had been lost when a woman goes through menopause, which we can talk about what that is, to prove that it really decreased cardiovascular risk in women. And after just a couple years of that study, the findings started coming out, and it started to show that there was actually an increased risk of cardiovascular disease and breast cancer. And they stopped that study early because these findings were coming out that it was actually more harmful. Unfortunately, now what we know about that study is that the actual results were inaccurate. And they preemptively came out with results that were completely false. And so that those risks that they were claiming, increased cardiovascular risk and breast cancer risks particularly, stopped all providers from prescribing, stopped all education on the topic in medical schools, in any kind of nurse practitioner PA programs. And so since early 2000, nobody has been practicing this part of medicine in like mainstream corporate medicine, and nobody's been taught or trained in this field of medicine. And so anybody who wants to do this medicine has to go out on their own and study it themselves. It's not just being taught in programs. And so that is why we have a big sort of spotlight on it now, is that we're finally getting more research dollars towards menopause and perimenopause. the current women, the current generation of women that are going through perimenopause are not going to put up with, like, you just have to grin and bear it, as the baby boomers had to do. We just have a lot more options that are just a lot more, they're more efficacious, they're safer, and there's just an ability to treat the whole woman individualized in a way that we didn't before.
When I was in medical school, that's what we were taught was based on those studies. So yeah, I'm very interested to talk more about the cardiovascular risk and kind of the newer data with preventing plaque calcification with hormone replacement. But I'm curious just about that story when you decided to move out of the system and do something on your own because you felt like it was the right thing to do.
Yeah, that was
and then maybe we can break down what menopause is. Yeah.
Good. Yeah, that was a big move. I mean, nobody was really doing that. In my career, I have seen private practice, I have seen medical professionals, providers, go from only private practice to then flip, in my community, to all corporate medicine. And now, just in the last few years, some of those corporate medicine doctors are, like I did, getting fed up and moving back into private practice. And so for a lot of reasons, I was, just to be totally frank, feeling very miserable in my role as a corporate medicine midwife. I was being told what I could and could not do. And I think, and what we had time to do and how long my patient appointments needed to be. And I was very much being dictated how I could function as a medical provider. And because I had worked in private practice before going into corporate medicine, I knew that there was so much more that I could do that I didn't need to be told what I could and could not do. And so luckily, from a financial standpoint, I was able to leave right before COVID hit, which, about 6 months prior to COVID, I just decided I was done. My husband had started his own business, and I was able to sort of take a break. I was feeling immensely burnt out from just nights up, then following days post-call seeing patients. It was a lot of transition in the practice I was in terms of leadership. And so I was feeling burnt out, not only from the patient care part of things. I also had twin babies at home. I had just given birth to twin baby boys. And so I just needed to take a minute. And in taking that minute, I dreamed up I took like all of the bits and pieces of what really amazing women's health care could look like. And sort of just decided either women are going to come or they're not. And they came. They came. And really, I led with fertility, because fertility is not unfortunately, it's not a well reimbursed part of medicine. Like, it's not often. And so I decided.
A lot of it is private pay.
It's private pay.
Like, regardless.
Yeah, regardless. And so I decided really right off the bat to not involve insurance in my new model. And that would mean not taking insurance as coverage for my care. I'm able and do use people's insurance to do diagnostics and lab tests and call in prescriptions if they need them. So we can use insurance, but for my time with the patient, I don't involve insurance at all. And that allowed me to offer really long appointments. And that's what I really felt was a big gap in care within the corporate medicine model, because insurance companies and their reimbursement rates are so low. Providers are needing to see 3-4 patients per hour in order to actually come out ahead. And so in the corporate model, that's what we were up against. So I was getting to spend maybe 10 minutes with each patient in my corporate medicine job. And now I get to spend a full hour with a patient. And that time is not dictated by anybody outside the room. That time is really a collaboration between me and the patient. And that's what makes this care so special. It's, what we can do in an hour together would probably take 6 visits in a corporate model. Because
in maybe 3 months,
yeah,
right?
exactly.
Yeah.
So we can get, I saw 3 patients this week follow up that I have seen maybe 3 times, and they went from feeling like dirt to feeling like close to 90% improved just over 3 visits. And their life feels like they have their life back. And that's been in probably 6 weeks because I'm able to see them do what I need to do, follow up very quickly, and then they can live their life and they can go on and they can be the amazing CEOs that they are, the mamas that they are, and just thrive.
Yeah. I think we're all bonded by the experience of working in corporate medicine, or basically medicine, corporate medicine is like, breaking it down, I think it's just what people think of as medicine, insurance-based, large system healthcare, where the way that providers, prescribers operate is based on what management or the equity group that owns the hospital or the clinic tells. And more so it's dependent on volume rather than quality. So I think we're all kind of bonded by the fact that we would rather do quality, which takes time and thought and personalization. So I just wanted for you listening to kind of get a sense of why that shift happened and why it's so successful. Because
so when we opened and fertility was kind of my focus, and I started to realize there was this big revolution in the perimenopause, menopause space coming down the pike, and what a gap in care there was because of the Women's Health Initiative study. And then not that long ago, that Women's Health Initiative study was reanalyzed, and the new findings were made public. I thought, gosh, this would be a really amazing addition to the practice. And so because I'm small and agile, I could pivot and I could easily add that as a specialty in the practice without going through 6 months of committees and people deciding if it was worth their while to add this specialty. And so we just opened the doors to that.
It's just so cool.
It's so cool.
It's so cool. I'm just smiling. Like, I also should say, like, I've seen a little bit of your arc in your private practice, and it has just been, it's such an honor to be a witness to your success.
Well, again, if you put the patient at the center, so then we thought, okay, let's add menopause and perimenopause, and let's do that. And I thought, gosh, how much better would it be if we had a multidisciplinary team? How cool would it be if we had in-house therapy and pelvic floor physical therapy and functional nutrition? These are all things that build a team around getting somebody really from surviving to thriving. And so I started to just kind of put those feelers out. And a lot of people were really excited about what we were doing, but it was kind of like, okay, who's going to stick? It's like kind of like throwing noodles against the wall. Like, a lot of people are interested and excited, and like they see the growth and they see the beautiful waiting room, and our exam rooms, are very, very comfortable.
It's such a therapeutic space.
It's a very therapeutic. So they come in, they're super interested. However, it's like, does it stick? And so over the last 2 years, we've grown really into a multidisciplinary team. So we have another advanced practice clinician, another midwife, and then we're adding a physician in the new year. We have pelvic floor physical therapy. We have 3 therapists and a functional nutritionist.
All right, well, let's break down.
Yeah.
What is menopause? Why is it important?
Yeah.
Why is this needed in the community?
Yeah, well, women spend about 20 to 25 years in their reproductive years. So that's when, puberty is when a female starts their period usually between the ages of 12 and 14. They spend several of those teen years with really irregular periods as like the ovaries are sort of warming up, getting used to cycling. In the 20s and 30s, those are really kind of the prime reproductive years. That's where we see the best ovarian function. We see women, we see if they're going to have regular periods, those are when the cycles are going to be coming monthly. And then as they reach the late 30s, early 40s, that's when sort of the ovaries start to go, I think we're going to start winding down here. And so really like women go through this huge transition in perimenopause from having fairly regular cycles and shifts of hormones that their body is sort of anticipating to really hormonal chaos. That's what happens. And that can be anywhere from 7 to 10 years prior to the onset of menopause. So the true textbook definition of menopause is 1 year without menstruation. And so what happens in that decade of perimenopause is the hormonal chaos makes for a lot of different symptoms, bleeding being one of them, but not necessarily being irregular bleeding necessarily being everybody's symptom. And so that fluctuating of hormones makes for like basically 30 to 40 different symptoms that can present itself. And then once you hit menopause, you go that full year without a period. That's when we see kind of some overlapping symptoms of perimenopause, but also some new friends show up. New players of symptoms kind of show up to the playground. And so we're really helping women manage through perimenopause, through menopause and beyond.
Yeah. I wonder, like if you're thinking about someone who's coming to you in the perimenopausal time, what's really bothering them? How do they present? What do they need from you?
Yeah. Well, a lot of times women have been having symptoms for a couple years by the time they've come to me. So I'm seeing most of my patients like mid 40s, sometimes early 40s, and they noticed a shift about 2 years ago. And they've gone to their providers, their primary, their OBGYN, and they've mentioned these symptoms, and they're like, it's nothing. You're too young for perimenopause. And so a lot of times when women are coming to me, they're really looking for validation. They're like, I know something has changed. I know it's continuing to change. And I'm just not getting any answers. And so a lot of times women, like, they just don't feel themselves. That is sometimes, and that is not a black or white thing. Like in terms of like, that is not just,
It's not diagnostic.
It's not diagnostic. They just don't feel like themselves.
Yeah.
They may have some, irregular periods, but oftentimes they feel some like emotional changes. Like they feel more easily agitated. They felt their anxiety increase. Some women they can't sleep anymore. Like they go from sleeping great and suddenly they're waking up every morning at 3 a.m. And that's not because they're having a hot flash or a night sweat. So, the textbook symptom of menopause is night sweats and hot flashes. We call those vasomotor symptoms. But
that's kind of what maybe gets the traditional medical establishment to be like, oh, we should do something about this because that's the clinical feature.
Yes.
But all of these other things that start to change, word finding difficulty, sleep issues, emotional changes.
A lot of energy changes. So women come in and they're just like, I am dragging. A lot of women lose their libido also. They lose their desire. They love their partner, but they want again. And I also see a lot of women in their 40s that are really having a lot they're like kind of in between stress 1 and stress 2. So
the sandwich.
The sandwich, yeah, absolutely. And so the stress of like taking care of kids, of, being kind of at the peak of their career, about, starting to take care of elderly parents. All of those stresses are starting to really kind of crunch them. And that can make the hormonal fluctuations within perimenopause almost amplified.
And I would imagine, too, that if you tell a provider who has 10 minutes that your life is really stressed out, and there isn't these other bigger kind of medical things to point to, that the stress becomes the women's issue, and there's no checking of the hormonal imbalances that
or
are
it's
at play.
just normal expectation,
Yeah.
right?
Yeah.
Like, oh yeah, of course, like you're taking care of people in both directions and you have a career. No wonder you feel bad.
Right.
That's just life.
And that's where the like I feel off. Like it's not just that.
Yeah.
Like this is life, but there's something else going on.
Yeah.
And we see that in therapy all the time. We're kind of the first stop of like something's up. And I don't know
People
what
present
it is.
for the emotional,
Right. And I send people to you all the time. I'm like, hey, just pay for it because let's figure out what's going on.
Yeah.
And if anything, it's a rule out. But oftentimes I would say things show up. And then they're so grateful.
Yeah. They're so grateful.
Let's walk through what actually happens in perimenopause and menopause.
Great.
Hormonally.
Yeah, from a hormonal standpoint. Great. So I have a whiteboard in my office, so I love that we can do this today. So when we think of a cycle, like a 28 to 30 day cycle, we think of it kind of in two main hormones, estrogen and progesterone. So if this is kind of our graph, this is the month in days. This is the last day of your cycle. So let's say that's 28 days. And the next day you're going to start your period. Then this first day of the cycle, cycle day 1, is your first day of bleeding. And somewhere between cycle day 1 and cycle day 28, usually about in the middle, cycle day 14, if your body is reading the textbook that month, is when ovulation happens. Okay? And so this first part of the cycle is called the follicular phase. And that's when the ovary is growing and maturing eggs and an egg that will eventually ovulate. And then from cycle day 14 to 28, that's called the luteal phase. And that's when the egg has been, has ovulated and released and goes looking to see if a sperm will find it. And that is where we see implantation happen if a pregnancy is going to occur. The first half of the cycle is estrogen dependent and dominant. And so we see an increase in estrogen over the course of the first 14 days. At ovulation, we see a peak in estrogen. And then for the last couple weeks of the cycle, we see a decline. The second half of the cycle is progesterone dominant. And that's so right after ovulation, we see a peak in progesterone. And that comes from the corpus luteum cyst where the ovulation happened from the ovary. And then we see a decline. And so this is where a lot of women feel PMS symptoms in their regular reproductive years in the 20s and 30s.
What is PMS?
PMS.
What is that thing?
So that stands for premenstrual syndrome. It's things like mood changes, libido changes, energy changes, and just an overall feeling of not feeling well. And usually that is a couple days before the period starts. Well, in perimenopause, the hormones look a little different. Specifically, estrogen, instead of being sort of this curve, this beautiful bell-shaped curve, it looks more like this. And then you hit menopause, and all the hormones are very low. Okay? Yeah. So hormonal chaos is what I call this. So in perimenopause, because we have this hormonal chaos picture, 1 second of the day or the week, we might have hormones here. The next, we might have our hormones here. The next, we have hormones here. The next, our hormones are here. So we're in this perpetual PMS situation. And so if PMS was a problem for you, symptomatically for a couple days in the month, it's now all month long. So women really feel miserable. And some months reverts back to the beautiful bell curves. And your ovaries are like, we are on point. And then the next month, they're like, nope, we're in chaos again. And so you start to women start to feel like they're going crazy. They're like, I'm good 1 month and I'm really not good the next. And so that's kind of what is going on in all tissues of our body, because hormones are everywhere. So our brain responds, our breast tissue responds, our endometrium or the lining of our uterus responds. And so that's why we see such a vast array of symptoms. And from person to person, that list of symptoms is different. And so it makes it very hard for in a 10-minute visit with a provider to really be able to figure out what's going on and how this patient could be best optimized. It also mimics a lot of symptoms of other things like hypothyroidism or low iron. Those are just two examples, or really low other nutrients. So I think, it takes time to be able to sort of be a detective in this space and figure out what is really going on here. And so that's the hormonal picture that we're dealing with when we're talking about perimenopause, and it can last 7 to 10 years.
Yeah. So if someone comes in, you have a clinical suspicion about this might be perimenopause. Just for you listening, what else are you also making sure it's not?
Yeah. So I actually do a really quite thorough lab analysis for patients, because when they come in their 40s, they've often not had super amazing primary care leading up to this transition, mainly because they've been mostly healthy. And again, our corporate medicine model is about helping, like really treating the sick people. And so when a relatively healthy woman comes in not feeling herself, it's not been like bells and whistles, we got to like sort this out already. So I check a lot of nutrients. I check their levels of ferritin. I check all the hormones. So I do check estrogen, progesterone. I check testosterone. I do a full thyroid panel. So I check thyroid, TSH. I check a free T3, free T4. I work them up for Hashimoto's. I find a lot of Hashimoto's in perimenopause, because even in addition to going through menopause, because of all the stress that they're under, a lot of times we see some autoimmune disease popping up in this decade. I do a complete blood count, and then I look at their metabolism. So I look at how they're processing their sugars. I look at a fasting insulin and a hemoglobin A1C and glucose. And then I look at sort of what their inflammatory burden is. And so I do check a high sensitivity C-reactive protein.
Okay.
So that's kind of like my big workup, in addition to vitamin D. I find a lot of vitamin D deficiency, and I check their vitamin B12 levels. And so it is pretty thorough, but it's not anything really out there either. And so
Do you get an ESR set rate?
I don't get an ESR. And I gotta be honest, like checking a high sensitivity CRP is sort of new for me. It's not something I've been doing for years.
Even in psychiatric practice, it's kind of been an interesting, as we're talking about neuroinflammation in the brain as being part of the underlying mechanism of disease.
Yes.
It's been interesting which patients have kind of like this unspecified inflammatory
response.
Yeah.
So I've just been sort of adding the CRP, not quite the SED rate yet.
And I have no idea if a SED rate's relevant, but I think CRP, I think ESR, so that's why I asked you.
Yeah, absolutely. So, and the hormone part of it, like that testing is a little bit controversial in perimenopause, which I want to touch on, because like my diagram showed, the hormones are all over the place.
I was just thinking that. Like, at what point do you test the hormones? Does it matter at what point in the month they get tested?
So I just do a random. I don't tell patients you got to go on the first or second day of their period or post-ovulation. Like in fertility world, those days are important. Yeah. But for perimenopause, they're going to probably be all over the place anyways. I'm using that because I'm getting those levels because I'm curious and not so much because they're going to be diagnostic for me.
And maybe time points over months or years as opposed to...
Exactly.
Okay. Yeah, you're for sure perimenopause because you're FSH, LH,
Yeah, so I'm not necessarily using blood work to diagnose perimenopause.
Yeah.
It's not like I'm going, I'm checking your FSH, and if it's a certain level, that I would use in a postmenopausal woman. And so...
Which I think is really important because even like my mom is going through this, and so
Yeah.
the doctor was like, oh, we're gonna test your hormone levels, and then, oh, well, it doesn't say that you're, and I'm like, I don't know that that's the right.
No. Yeah. So there's a lot of confusion around this. And that's the other, I think, reason why why there's a lot of noise out there. There's a lot of confusion. And so I do mention that like hormone testing is a bit controversial in the menopause, perimenopausal space. And that's because it's not really what we're using to diagnose. And I tell that to patients. I say, because if you go to somebody else and you ask them for hormone testing, they may not even want to do it. I'm always like, if you're curious, I'm curious. And so again, it's not
Who isn't curious about their hormones?
Totally.
As a woman,
Yeah.
I mean.
And sometimes things really show up and I'm like, oh, I'm so glad we checked those. But I would say more often than not, I'm looking for other areas to optimize their health
Yeah.
and rule outs. And so I get a lot of women who come in and maybe they have no thyroid abnormality. Most of their symptoms are probably because they're perimenopause and they're in this hormonal chaos. They're not sleeping well. They're feeling super agitated several days out of the month. They don't have good energy in order to exercise and make good choices around nutrition. And so if I get their labs back and their ferritin is 9 because they've been having heavy bleeding and their vitamin D is 18.
These are low.
Yeah, these are low levels. And I give them a little bit of support in the way of supplementation, as well as talking to them about how we can make their period a little more tolerable so that they're not losing so much iron every month. And then maybe support them with a hormone option. They're a new person in 3 months, like a new person. And so, so I check the levels, all those levels, because I am looking for other optimization points versus like using it to diagnose perimenopause.
Are you doing IV iron?
No, I'm not. I'm not. I am
For low ferritin.
Yeah.
I'm just curious. It's not also custom.
Yeah.
Or standard. But.
I've had patients do IV iron, and I just feel like it's more of a hematology corner than mine. I usually, because I'm in gynecology, I can help with the periods. So if somebody's having really heavy periods, if that's their symptom of perimenopause, we're talking about how to get to the root cause of their heavy bleeding. And so sometimes that's, a discussion around a Mirena IUD or a discussion around birth control pills. And oftentimes, even just getting them feeling so much better and supplementing will get them to the point where their ferritin is 20, not optimal, but at least the symptoms from between a ferritin of 9 to a ferritin of 20 feels a lot different for the person. So if number one, I can't get their iron up with supplementation and they're not interested in either an IUD or a birth control pill to control, and we go, 3 or 4 or 5 months and their ferritin's really kind of staying at 9, I am referring them to hematology. And I've had a couple patients have really great success with iron infusions. What they often will find, if the periods really can't get under control, they'll get their iron infusion and feel great and then bleed and it all goes away. And so, but again, like I lead with curiosity and support. Like this isn't my process to manage for them. It's really their journey to walk through. And I think that's the difference that I'm able to provide as well, is that they really feel in control of the decisions they're making. Of course, if they're bleeding so much that I think they're going to have to go to the ED for a blood transfusion, that's a different story. But most of my patients are not there. They're just not feeling good. And they're going to keep not feeling good unless we make some changes. When we're thinking about hormone replacement therapy, we're really thinking of menopausal hormone replacement therapy. So if we kind of reverse back to the reproductive years, when we're thinking of how do we use hormones in those reproductive years, that's going to be like birth control pills. And so that has a completely different purpose than hormone replacement therapy. They're the same type of like molecular chemicals, but they have completely different structures because they have a different purpose. Birth control pills really are meant to prevent pregnancy and control bleeding. And menopausal hormone replacement therapy is meant to support that hormonal chaos or lack of hormones altogether, if you're in menopause, that the woman is experiencing. And so I think it's really a common myth that we don't use hormone replacement therapy in perimenopause. And I see that a lot. So I see a lot of women who come in who are still having regular cycles, who are not feeling good, and who have been told by their OBGYN or their primary care that they have nothing to offer them except for birth control pills because they're still having cycles. And so that is like, I think, a huge area of optimization for women who are in perimenopause for 7 to 10 years to really feel better. And so when we think about birth control pills versus hormone replacement therapy, we're really thinking about totally different purposes. So when we use hormone replacement therapy, we're really using it to support the symptoms. We're not using it for birth control. We're not using it for bleeding control. And so when a woman comes in with a list of symptoms, whether, in perimenopause or menopause, whether that's sleep issues, mood issues, hot flashes, night sweats, libido issues, I'm really starting to think of her as like, okay, what hormones are either low, high, or missing? And is the delta, the change in hormones, the issue? So that's kind of what I'm thinking. And in her story, I'm able to sort of make a really educated guess about what hormone, estrogen or progesterone, or both, would be helpful for her.
Like, say a woman comes in and is like, my period's getting closer together.
Mm-hmm.
It's really a 25-day cycle.
Yeah.
She's 40, and she's not sleeping at all 3 days leading up to her period.
Yeah.
What's happening?
Yeah. So what's happening with her?
I feel like this is the most common thing. I hear this all the time.
Yeah. So what's happening with her is she is in her luteal phase, and her corpus luteum, that little cyst on her ovary that ovulated her egg that month, it probably isn't quite as healthy as it was when she was in her 20s and her 30s. And so those cells are not producing the same level of progesterone that they were, number one, earlier in her cycle and earlier in her life. And so her cycles are shortening because her corpus luteum is kind of running out of progesterone a little early. Progesterone is kind of a calming hormone. So it helps a lot with sleep at night. It helps a lot with mood and anxiety, lowers anxiety. And so we see shortening cycles because the bleeding profile is different. And then we see sleep and mood changes as well, sometimes together and sometimes separate. And so what's going on is that corpus luteum isn't actually like sort of showing up to work the full second half of the month. And so we're seeing those changes and those symptoms. And so usually what I would do in that kind of a situation is I would get to the bottom of what's bothering her. So that's like really, again, patient-centered care. What's bothering you? Is your period the number one thing that's bothering you? Is the sleep bothering you? And I also like to think outside of the box of hormones because there's a lot of supplements and other modalities that we can use. So if a woman comes in and says, I really, for whatever reason, I'm sort of hormone averse and I'd rather do this sort of a more natural way, I'm like, great. I have a lot of tools in the toolbox. So magnesium glycinate can be a beautiful tool for sleep. And so a lot of times I'm making recommendations that are also non-hormonal. So for whatever reason, if a woman wants to start maybe without a hormone as a first line, we can always do that. Most women are deficient in magnesium anyway, so it's kind of a twofer. And then another hormone that does not get mentioned a lot for women in this space is testosterone. And so women have testosterone. In fact, if you're measuring estrogen to testosterone, women actually have more testosterone in their body than estrogen. And so that is kind of a very forgotten hormone for women because here, especially in the US, we've genderized sex hormones. And so we think of women as having estrogen and progesterone and men as having testosterone. We don't see quite the same hormonal chaos picture with testosterone as we see with the other two hormones, estrogen and progesterone. We see more of a linear decline in testosterone over perimenopause. And then interestingly enough, when women get into their like late 60s, early 70s, we see a bump in testosterone, which is, we're kind of curious about why that's happening. But we see some symptoms of low testosterone in perimenopause and into menopause as well. So I wanted to mention that because we've been talking a lot about estrogen and progesterone, but kind of the cherry on top for a lot of women is some testosterone replacement therapy as well.
And how does that, what does the testosterone replacement solve in this picture?
Yeah. So a lot of times we see low testosterone manifesting itself in the way of low libido, low energy, difficulty with maintaining muscle mass. So my women who like spend a lot of time working out, lifting weights, they're just not holding on to their muscle mass or able to build muscle mass like they used to. We also see testosterone replacement therapy help mood as well. We really only have guidelines around testosterone replacement therapy for postmenopausal women. And the only indication we have, which I find really interesting in our society, is low libido. So whether or not you want to have sex with your husband or not is the only indication we have for testosterone replacement therapy.
Sounds designed by men.
Mm-hmm. Yeah. And we unfortunately don't have an FDA approved product for testosterone in women. So there's a lot of barriers to access for testosterone replacement therapy for women here in the United States. And it's unlikely we will have a product that's FDA approved anytime soon.
Very interesting. What I've been curious about, I know it's obviously it's a shared decision between you and the person that you're seeing about whether or not hormone replacement makes sense, and whether or not it's indicated. I've been curious about how you think about hormone replacement as a preventive, as opposed to like, I have these symptoms. Oh, I'm okay with these symptoms or manage them in another way. But that estrogen deficiency also has longer term issues. So I wonder how you think about prevention with microvascular changes, coronary artery disease, lipid,
all those.
Yeah.
All those, because the number one
bone density,
the number one.
Oh yeah, isn't it like the number one
cause of death,
mortality
is heart disease.
And heart disease, and also for women is like a broken hip or something.
Yeah. So those
like if a woman falls and breaks her hip,
she has a 50% mortality rate.
Yes.
Yeah. So prior to the Women's Health Initiative study, we were doing preventative hormone replacement therapy on almost everybody. So basically it was not an individualized, it was like, oh, hi, you're here for your pap smear. You are menopausal. Here's a prescription for Prempro, Premren. Here, you'll just start this and I'll see you next year. So every woman got the same prescription, got estrogen replacement. And if a woman has a uterus, in addition to estrogen, they received progesterone, and it was in a little combo pill. It was not like body individualized for what our body makes. That form of estrogen is actually from horse's urine. It's
awesome.
Yeah, it's conjugated equine estrogen. So pregnant mares, they would collect the urine from the pregnant mares. They would extract the estrogen, and then they would package it. I'm sure it was a lot more complex than what I just described, but it was. I mean, actually, it was female horse estrogen. And then it was a different type of progesterone than we use now. And so everybody got that because we had small studies showing that it was preventative for heart disease, and heart disease being the number one cause of death for women and men. We put everybody on it. And when the Women's Health Initiative study showed an increased risk of cardiovascular disease, which we can break down what it showed and why it was inaccurate, that's when they thought, oh my gosh, have we been doing this wrong all along? So, it was a big pendulum swing. I mean, it went from everybody got it to nobody was getting it. And what happened was that there was a proportion of those women that were put on hormone replacement therapy that actually really needed it for symptom management. And so those women started to become miserable. They were like, wait, I can't have my hormones? I am like flashing 15 times a day. Like my vagina feels like sandpaper. Like somebody help me. And it was like radio silence. And so a lot of like alternative practitioners like our naturopaths, our chiropractors, our acupuncturists were starting to use compounding pharmacies because that's the route that they're able to sometimes prescribe through to get bioidentical. So again, away from the horse urine story, bioidentical hormones. And when that subset of women started seeking care from other providers, other medical providers, alternative medical providers, that's where sort of the popularity of bioidentical came from, because compounding pharmacies were able to make medications that were not necessarily at your, neighborhood CVS, that were bioidentical, that were helping to serve this group of women that were like, okay, great for prevention, and it's fine that we're not doing that anymore, but I am miserable for a multitude of reasons. I can't just say goodbye to hormones for the rest of my life. And so over the course of the last really almost 20 years, 15, 20 years, we have seen big pharma see where the financial benefit of bioidentical hormone replacement therapy has a place and where money can be made. And so here we are now with a lot of FDA approved bioidentical or sort of human body identical estrogen, progesterone, and testosterone options. For women, we don't have something that's testosterone FDA approved for a woman, but it is bioidentical to what women and men have. We just use 1/10 of the dose for a woman.
Okay.
Does that answer your question? So prevention, the take-home message on prevention is I do not think in my career time we will see the pendulum swing back to prevention. I think a lot of people in my bubble of menopause and perimenopause medicine definitely know the studies, definitely feel that there is a huge prevention benefit for cardiovascular disease, for bone health. I think most of the patients coming in to see me have an indication for hormone replacement therapy. So if they're either way.
Yeah.
So if they're like, I am really interested in the prevention and I have 4 hot flashes a day, or I have some vaginal dryness, or I have a family history of osteoporosis, any of those meet the indication. And so while, as you know, in medicine, we use a lot of things off-label. We don't often have to find ourselves in that place. Oftentimes, we can find an indication in a woman, even if we think this could be just prevention alone is a good indicator. We often will have an indication for something else that is fully indicated. I don't think we'll see the pendulum swing all the way back to that in my the time I'm left here to practice medicine. But I do believe that there is a place for prevention, especially around cardiovascular disease and bone health, as well as I think we're going to see some cognitive prevention as well.
That's a good segue to mental health. I think it's pretty sad that we're in the sick system. We're not in the prevention era yet. Maybe we'll get there. But what I think about so much with your practice and how you approach care is to listen and to hold space. And what comes out of that is a mistrust in the medical model and a hopelessness that people come in with when they first see you. And then you're up against this education of what to do.
Yeah.
And I don't know if you want to speak to any of that, because it's a big ask for you to be taking so much of this broken system, these people who are at, a rock bottom maybe, or just feeling like minimized, and 2 or 3 years of just, what's wrong with me? Something is off. Please believe me.
Yeah.
And
I think that's the key. I think we need to believe women.
say it louder.
I know. I think we need to believe women.
Yeah.
And, it's, we've gone so many decades of thinking many of the symptoms in women's health and mental health is all in the head. And that there isn't like a realistic diagnosis or root cause that we can work towards.
the hysterical woman,
Mm-hmm.
the hormonal woman who can't make decisions because she's just, on her period.
Mm-hmm. Yeah. Yeah. So, I mean, I think
Very problematic.
yeah, exactly. And that is actually the reason they used to not study women prior to about 2000. So we do not have nearly as much data on women, even in the realm of like cardiovascular disease, cholesterol, hyperlipidemia management, because most of all of the studies were done on men because women's hormones and all of the symptoms that go with changing hormones are too, they provide too many variables.
They're harder to control for.
They're harder to control for.
The mental health component to hormones and coming in and feeling minimized in the medical model. And when do you know if somebody needs therapy? When do you know if somebody needs pelvic floor? When do you know if somebody needs acupuncture, a little vitamin D, right? Like this multidisciplinary approach that you're talking about, it sounds like a dream.
Yeah.
Who gets that?
Yeah. Yeah. So, I mean, it goes back to sort of like treating the whole person.
Yes.
And also like being collaborative with the patient and believing the patient and also having the time and the bandwidth to look into some of the like harder corners of the body to find answers. And sometimes I don't find all the answers. And so that's why I really sort of build the expectations that especially if somebody's coming in, has been feeling not great for a long time, has a lot of different complex medical issues, we're going to build a team. And so we're going to build a team. And so that might involve acupuncture. That might involve body work. It might involve a pelvic floor physical therapist. And oftentimes, almost always, it will involve a mental health professional. Because by your 40s, most people have experienced some form of trauma. They're having they've been through a lot. They've had children. Again, they're dealing with aging parents. They're having maybe some marital strain or issues with their partner. There's stress in the workplace. So there's just so much going on that, like, even if I do all the amazing things that we're able to provide within my practice, there's often a mental health part of it that absolutely needs to be addressed. And so, that is why the very first secondary provider that I brought into my practice was a therapist.
But you're saying it in such a different way, because I think so many women go into their first postpartum appointment and, it's a you problem. I don't want to hear this. Do you have a therapist? And it's just this like, I must be so bad. Like, I must be so sick that they don't even want to hear me, or, and postpartum depression and anxiety is so normal. And then, but you saying in conjunction with our work and you getting support for your mental health, because you're going through a lot, means so much. And you recognizing that that's such an important piece of it. But what the medical model somehow has done is make it the whole problem.
Yeah.
There's such a strong biological basis for these experiences, for it to be minimized into just an emotional problem, I think is maybe what you're talking about.
Exactly. That you being able to offer this multidisciplinary approach for women, I would imagine it just feels so good to know I have this help from Dana and her team, and also it's okay to go to therapy. And it's not the whole issue.
No, we're coming at it in so many different spokes. That's what's so cool. It's not like a one and done. It's like humans are complex, and that's beautiful. And it also means that if we're not feeling ourselves, there's probably a few things at play.
There's so much shame.
There's so much
shame in feeling, especially as a woman, in getting older, and the just the emotional side effects psychologically of getting older, or needing or feeling problematic, women putting themselves first. allowing ourselves to go pay privately outside of insurance to get answers. You know, I think there's a lot of questioning of, am I deserving of this? And when they get to you, I know just from talking with you, people crumble, and it's safe to do that.
Yeah.
And to just cry.
Yeah. It's okay. It's okay to grieve over the fact that, like, you have been telling other providers that this, I mean, again, it's often that this has been going on for several years. It's not like people just think, oh, I'm perimenopause, I'm going to go pay out of pocket to see Dana. You know, like, that's not, it's usually been, and so a lot of times they feel so relieved. They need to have an emotional moment to just go, I've been right. She believes me. There's answers. And I'm getting goosebumps.
I got goosebumps.
Because it happens every single day.
Yeah.
It happens every single day. And
what does that say about our system?
yeah.
It's just, and you're booked out.
Yeah. And my dream, I mean, people ask me every time I talk to people, they ask me, well, are you going to ever take insurance? And my hope is that someday we'll be able to have this care and this will be mainstream. At this point, I can promise you it is not going to hit mainstream medicine anytime soon. We are getting corporate medicine is getting, and providers are being squeezed and squeezed, and it's going to have to get very, very tight before it loosens up. And really, we know from insurance companies, they're not necessarily the ones looking to future patient-centered care. And so, you know, if I were to just wait around until I could take insurance, I would never be offering this care within my career. And so, you know, we try and do all of the things we can to save people their resources, like using their insurance for labs and prescriptions. And we're able to keep our prices fairly reasonable. But at the same time, like, this care is such different care than what they're receiving from anywhere else, that they come in and they're like, this is worth it.
Yeah.
I have a clinical question about serotonergic, like, antidepressant medications in perimenopause and menopause. And when, like, in your perspective, when is that relevant? How does that apply?
Yeah. So when we're thinking about mood changes in perimenopause, so basically the estrogen fluctuations, the delta, not only the estrogen being high sometimes and low sometimes, but also the change in those hormones rapidly, is where we see kind of neurotransmitters, definitely not the brain, not being super happy about that. And so obviously there's a couple different ways, and those symptoms, the symptomology, or the symptomology of the brain not being happy about that either the hormone levels or the change in the hormone levels, it can be emotional changes. So anxiety, depression, increased agitation, we see a lot. Just people feeling more edgy, feeling like they're just agitated more easily than normal. We can treat those a few different ways. I mean, I can write a prescription for the woman to go to Morea or Tahiti tomorrow. That would probably make her feel a lot better. You know, like, just take away all the stresses of life. Well, that's not exactly realistic for all. I can offer her some hormone replacement therapy, and I can see if just giving her body, her brain, a little bit extra support in the way of, there's always going to be some hormone here, brain. The brain is a lot more comfortable with having that low dose, regular exposure of one, either progesterone or estrogen or both. And so that's where I see kind of the first line with my patients, is if they're perimenopause or menopausal and they're having symptoms of any kind of mental health symptoms, I tend to lead with hormone replacement therapy unless they have a contraindication. And again, we can usually find an indication elsewhere outside of mental health concerns that allow us to do it on label if I feel like that's a necessary component. And so if for some reason I think this isn't related to hormones, most of my patients coming in I usually have a suspicion that it is related to hormones. If I don't think it's related to hormones, then using an SSRI can be really helpful. I do this a lot in, or more frequently, I would say, in my PMDD patients. So my patients who have, very severe emotional changes around their PMS time that we talked about earlier. So maybe like their symptoms are just so much more severe that it's truly affecting their life. Maybe their symptoms are longer. Oftentimes, depending on what they're doing for birth control, I will often add SSRI. Particularly my favorite is Prozac or fluoxetine, because I can use that for a few days at a low dose for just this section of their period that they're feeling their most symptomatic times.
Like 5-7 days before
Something like that.
the menstrual period.
And then they can use it as needed. And so, so it kind of depends, but I tend to lead because it's my specialty and I feel really comfortable with hormones. And because I feel very comfortable with hormone use, I tend to lead with hormones first in the area of mental health, but I don't shy away from any kind of anti-anxiety or antidepressant. I do try and stay away from benzos in my patients with anxiety and sleep issues. I try not to treat...
Like Xanax, Klonopin, Ativan.
Exactly.
Yeah.
So I see a lot of patients coming in to me. I mean, you would be shocked. I see patients coming in on Seroquel for sleep because their provider, their primary care provider...
For sleep changes in perimenopause?
For sleep changes.
Wow.
For sleep changes. And I'm like, has anybody ever tried some progesterone with you? And she's like, nope, Seroquel. And I'm just like, oh, or a lot of people are...
Which compounds the metabolic issues that happen in menopause with cholesterol changes. And
Yeah. So it's just fascinating. So my field of specialty is really hormones. And so I tend to really be able to pick out symptoms and kind of connect the dots on which hormones I think will help the specific symptom profile the best. And then what I do is I layer those hormones on. I don't just say, hi, nice to meet you. I'm going to give you 3 hormones. And then you're going to go away and come back in 12 to 16 weeks and we'll see how you're doing. It's like, I'm going to start with 1 hormone. We're going to see how that goes for a few weeks. See how you feel. And then I'm going to see you back in 3 weeks. And if you're not feeling like the amazing woman that you are, we're going to layer on another hormone. And oftentimes we see the symptoms, whether they're emotional symptoms, physical symptoms, bleeding symptoms, we see those symptoms start to really kind of wash away. And it's slow and it's predictable, and women can tell whether or not they're having any odd side effects from the hormone replacement therapy, because that happens as well. And so instead of like just throwing 3 prescriptions at somebody, I'm able to really sort of layer it on in a way that their body can adjust and then they can also adjust. And we don't have to then sort of reverse engineer which hormone was problematic.
Yeah. Are there times in which the response to hormone replacement therapy for the psychological, emotional symptoms isn't as strong, and or there's a safety risk and you're not going to use hormones, that then Prozac, fluoxetine, sertraline, Zoloft, those kind of...
Lexapro? Yeah.
That those medications in either condition become more relevant?
Yeah. I would say, once patients come in, a lot of patients have already been offered those medications by the time they've come to me.
Because they're easier in the primary care than the hormone. That's interesting.
Yeah. And I feel like a lot of women who are coming to me are pretty well educated in this topic, often more because they've had to be. They've had to become more educated. And so they've read the chapter in the book where for the last 20 years we've been treating menopause with SSRIs. And they're coming to me for a different approach. And so I often find women...
There's a different persona coming to you. That's interesting.
Exactly. Yeah. So I would say like it's all tools in the tool belt, you know, like it's all there. I say there's a buffet of options and more options than I can even fit on this table here to offer you. I am going to take the next hour to sort of really figure out what's going on with you, what symptoms are bothering you most, and how I think we can get you feeling close back to how you want to feel fastest. And then over the course of the next 6 months, we're going to work to tweak that, fine tune that, and then like sort of deal with the bumps in the road that are going to happen because this is a changing landscape. And so,
Even that, like, is just beautifully said.
oh, well, thank you. I mean, again, it's really putting the patient at the center of care and like setting expectations and doing, I guess, practicing medicine in the way that when I was that, you know, very naive chemistry high schooler, the way that I envisioned it. And I had to kind of go through the ickies of medicine to find myself back in the area of practicing the art and then being able to appreciate what that brings to the patient experience.
Yeah.
Yeah.
It's really beautiful.
I feel like that speaks to like all of our individual stories.
The art,
The
dance,
The healing.
the healing. Yeah.
Absolutely.
The having somebody in your corner along the journey of your healing.
Yeah.
Yeah.
Providers are really unavailable these days. They're unavailable because they're burned out. And I don't want to generalize, but a lot of medical providers are in some kind of state of burnout.
My primary care colleagues have 2,000-3,000 patients.
Yeah. The OBs, my OBGYN colleagues are so burned out. And we've moved away from individualizing. Like we used to know, okay, you know, Dr. So-and-so likes this in their room. They want this and that, and they want to do this. And we've moved to like standardization because standardizing is more efficient. Any kind of MA can come in and knows what to set up. And we've lost the art. We've lost the ability to, you know, be providers that are different than each other. And really, like when I was practicing in corporate medicine, I was being forced to practice in a box that I was breaking out of every other week.
You're supposed to fit.
And that was super annoying to admin. I was super annoying to admin.
Yeah.
They'd be like, we got her in the box today.
Yeah.
And then like I'd like punch out the front or punch out the back.
I was talking to family medicine colleague the other day who works in community. So not corporate, but similar system issues. And she was like, you know, we were talking about managing time. She's like, you know, I think you can either have an efficient doctor, you know, when you show up at 4, you're roomed by 4:05, or you can have a good doctor when you show up at 4 and you're seen at like 5:15. But I don't know that I've really seen both.
Yeah.
You're either on time or you're providing quality of care.
That's right. Because as a provider in any specialty, you don't really know if that next patient's going to need 2 minutes of your time or an hour and 2 minutes of your time. And if you're going to really provide the care that that patient needs and you're going to be patient-centered, you need to have some flexibility. And most patients need more time than less time at this point. And so.
Yeah.
Okay, I have one more question for you before we wrap up.
Yeah.
If
Great.
that's okay. I don't know, you might have some more questions.
Oh, I mean, I have dozens, but
okay.
we should
we
probably
each get-
have
should we each
lunch
get a
at some
question?
point. No, go ahead. Go ahead.
Probably.
You've both been granted a question.
Great. Call on me first.
Okay, you. Kayla.
Why is perimenopause and menopause a male issue just as much as it's a women's issue?
Such a great question. Yeah. You know, this is a process This is a journey. And if our partners aren't along for the ride, it can be devastating to a relationship. Just like women feel dismissed by their medical providers, if they're feeling dismissed, discounted, and unbelieved at home, it really puts a big crack in the relationship. Partnering from 40 and beyond is like a new chapter. It's a new chapter in life. It can be so beautiful, and it can be broken. It can be rocky. And so, you know, it's a male issue because if you want to continue to have the intimacy, the connection, if you want to continue to grow together, if you're not interested in what she's going through, you might lose her. Yeah. And that's why we see 50% of women, partnered women, divorcing in perimenopause because there's a lack of understanding and there's just a general lack of like wanting to understand.
That's what I find. It's like this is a you issue. You need to go figure this out, and not a family functioning systemic issue.
Yeah.
And something I was mentioning to Sir is you and I hosted a big event at the top of the year, and you know we had over 50 people there, and I was really disappointed that there was maybe one or two men there.
Yeah.
And it really made me pause.
Yeah.
And think how bad I felt for it was centered around this subject, the perimenopause and menopause, and it really made me pause about how much I had compassion for my mom that I didn't acknowledge. It certainly wasn't. It was like a laugh. Like we laughed about it.
Yeah. It was
You
more
know,
of like
her hot
a
flashes.
butt of the joke.
Yeah, like, oh, it's happening to her again. You know, that's not funny.
No.
And unless it's coming from the person, like
Yeah.
unless they want to laugh at it,
Yeah.
it makes me think that every man is going to have women in his life that are going through this, and how to know the nuances of checking in on her and not minimizing her.
Yeah.
And that hormones are scary to talk about, periods are scary to talk about, or it's like taboo somehow, that's like just a women's issue, and that we shouldn't really openly discuss it. And as you know, you and I are both raising boys.
Yes.
And so my commitment is to make sure he's pretty comfortable having these conversations.
Bravo,
Yeah.
Mama. Bravo.
Yeah. Okay.
Yeah. Yeah, I feel like my perspective has also been because thinking about women in medicine and in health and clinically has been so understudied. It's a marginalized, it's a vulnerable community. And I think my orientation has been, like I should, my electives were more involved in doing women's health when I was in training, and I was, we have to do more to compensate for what hasn't been done in the textbook or what's not a part of their standard rotation. And I think that the more that we just care about other people and human beings and like have empathy in clinical practice, then it will be impossible to ignore the specific needs of women that have this biological development in these stages. So yeah, I think I'm hopeful that like as we all care about it, that other people will also care too. But yeah, it's hard for me to think about not wanting to know more or be curious about a population that needs special attention.
Absolutely. Yeah. Thank you for making it a topic of discussion. If it's important to your listeners, they will share. They will share what they learn. I think the biggest opportunity for growing this body of information is from the women, the population, sharing with each other. I have never been invited to do grand rounds anywhere. The medical institution right now is not interested in this topic. But our patients are. The people are. And so I think that's why I drop everything and jump at the opportunity to talk about this in a way that I can reach more people than just sitting across from my patients, which is amazing. And I do every day, all day, every week. But this gives the opportunity to reach so many more people outside of the state of California. So.
Well, we'll keep doing it because,
Yay.
you know.
Yeah, you better come back.
Yeah.
You got me.
Yeah.
Dana,
Dope.
I love you.
Aw, I love you too.
I love you too now. Like, I'm on the fan club.
Yeah, you're in the fan club
Yeah.
now.
Oh,
Thank you so much for coming on today. And we'll link everything on the episode, your website, and how to find you and all your socials. And yeah,
sounds great.
like, subscribe, do all the things.
Yeah, thanks for listening. Thanks for being here. I feel like I just had a master class, you know. This is deeper than I got in medical training. So I'm excited for round 2, round 3, round 4.
Let's keep talking.
Helps us be
Yeah.
better clinicians.
Thank
So
you.
yeah, we'll see you next time.
Sounds great.
Bye.
Bye.
Bye.